And it is truly my pleasure to introduce to you Sacharitha Bowers. And Dr. Bowers is an associate professor of clinical internal medicine and the Division of Dermatology, Department of Internal Medicine at Southern Illinois University. She is also the residency program there. She received her bachelor's degree from University of Illinois at Urbana-Champaign. And then the rest of her training was at Southern Illinois University for her medical degree, her internship, and her residency in dermatology. And I've had the pleasure of listening and hearing many of her presentations with regards to DEI, cultural competency, equity in medicine, and within dermatology, mentoring and professional development, as well as holistic well-being in medicine. And so I am just so happy that you are here today. This is timely in this day and age and societal issues, and how we can understand this issue of unconscious bias. So I'm just so happy that you're with us, and the floor is yours. Thank you so much.
Oh my gosh, thank you, Dr. Allen, for that extremely kind and generous introduction. You're making me brown blush. So let me hopefully see if I can successfully share my screen. Okay. So I trust you can all see this.
Yes.
Again, it is really, truly my honor to be invited to present at today's symposium. What an incredible offering for all of us, Dr. Allen, and all of the individuals who helped put this on. We are truly the grateful ones to be able to learn from experts across the country, and it's wonderful to be able to have our residents participate as well. So thank you so much for this opportunity. Today, I'm going to talk about unconscious bias. And like Dr. Allen said, I'm from SIU in Springfield, Illinois, and I have no disclosures or conflicts of interest. The professional gap that I'd like to try to hopefully fill today is first talk about how health professionals may be unaware of the inequity in our healthcare system as manifested by health disparities seen in our minoritized and marginalized patients. And then also that health professionals may be unaware of all the factors which contribute to these health disparities, including the role that unconscious bias plays and how to mitigate its effects. So hopefully upon completion of this session, you'll be able to learn a little bit more about unconscious bias. Hopefully you'll learn something new today, and you'll be able to describe how unconscious bias develops, how it actually affects our decision making, and then because of that ultimately leads to harm and inequity for our patients. And then lastly, I will review some strategies on how to mitigate bias, and with that, how to help build equity in healthcare. I'd like to start off with a story which is near and dear to me. A man approximately 32 years old came to the United States with his wife and young child. He wanted to immigrate here to pursue a better life with more opportunity for his family. He was told by a headhunter that the only way he would get a job is if he would change his name or use a different name for his job application, as nobody would hire him with his very long foreign name. So he used the name of all names, Bob. Yes, B-O-B, Bob. He justified this change because in his mind, it was a shorter form of the name Babaya, which was his father's name and his own middle name. He shortly thereafter received a job as a nuclear engineer in a new power plant opening in central Illinois. The year was 1981, and the full name of this man was Ramohan Babaya Mudlapudi. He went by Bob until his retirement, and proudly so, I may add, from this nuclear power plant in December 2019. 25 years later, his daughter would be told, likely in jest, of course, that if she hadn't changed her maiden name and took her husband's last name for her married name, she may not have gotten into dermatology residency. Haha, right? So This man is my father. This is him at our little retirement celebration we had for him. And of course, the latter example is myself. And I share with you this story because, as we know, entire identities are shaped and formed from our names. Our names are a marker of how we identify ourselves and how we identify other people. They are also, unfortunately, prone to unconscious bias and microaggressions and have been shown to affect everything from job placement to the career trajectory, from recruiting to promotion, and experiences of bullying and bigotry leading to feelings of shame and isolation and exclusion. And there are people among us who deal with this all the time. Bias affects our world and our daily interactions in a variety of ways, and we don't always see those on the outset. So it really is critical that we learn a little bit more about them. So why do we talk about unconscious bias in a conference such as today? My talk is definitely a departure from the clinical topics that we've heard this morning. And that being said, it is directly related because of the impact that it has in contributing to healthcare disparities of the conditions that we're learning about. So ultimately, to me, unconscious bias comes down to our central purpose, which in my opinion is a matter of what is just and what is equitable. And I truly believe there can be no justice without equality. However, as this popular illustration shows, I'm sure many of you have seen it, equality isn't possible without equity. The individuals depicted here in this first slide under equality can actually not equally partake in the experience because of their own limiting factors. In situations that are entirely based on superficial equality, everybody gets the same resources regardless of their personal circumstances, background, or starting place in life. So you can see how the outcome is actually not equal. But with equity, resources are tailored to meet the needs of the unique needs of individuals, so the outcome is actually equal. Well, unfortunately, in reality, we see that some individuals in our society have a much greater and disproportionate access to resources, while others not only don't have those resources, but may also have a disproportionately large number of barriers or life circumstances that put them at a disadvantage. What is the true goal? I love this adaptation of this popular depiction of equity versus equality, showing that the actual true goal, hopefully, is liberation. And what does that mean? That means removing the barriers so that there is open access for all individuals in our society to live a life that is a productive and healthy one, and they are living to their full potential. So I truly believe that to have justice, we must have equality, but to have equality, we need equity. And our prevailing societies agree that when it comes to equity, one of the biggest threats is structural racism and unconscious bias. And they have all developed statements to indicate as such. So when we're talking about health equity, it's important to have a shared definition of what we actually mean. Health equity, as according to the Healthy People 2020 report, is the attainment of the highest level of health for all people. It's actually quite simple. Health disparities are a particular type of health difference that is closely linked, and this is the important second part of this definition, with social, economic, and/or environmental disadvantage. The thing about disparities is that they can be used as a marker of equity. If health disparities are increasing, this is an indication that we have greater inequity. But if health disparities are decreasing, this is an indication that we are actually moving towards a more equitable society. And if we want to talk about disparities, which we should, it's important to touch upon this very seminal report that came out in 2002 that really ended up causing a subsequent sort of explosion of literature around healthcare disparities. This report was convened by Congress, and it was the first of its kind, and it showed significant disparities based on race and ethnicity, controlling for other variables such as insurance status, socioeconomic status, et cetera. And these disparities were seen in all types of diseases and disorders, ranging from cardiovascular care to cancer care, HIV treatment, stroke treatment, diabetes management, mental health, pediatrics, pain management, and so on. In this report, it was shown that Black patients were less likely to receive basic laboratory and diagnostic tests, certain medications such as blood pressure medications, diabetes medications, and some major therapeutic procedures such as limb salvage. Differences were also seen in physician communication behavior and physician perception of patients. This report, entitled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, in no uncertain terms, really made it clear that bias was a big factor. In the report, it states that the disparities in healthcare emerge from bias against minorities, greater clinical uncertainty when interacting with minority patients, and beliefs or stereotypes held by the provider about the behavior or health of minorities. They did not mince words, right? So with this report, we see that bias, stereotyping, prejudice, and clinical uncertainty on the part of the healthcare provider may contribute to racial and ethnic disparities in healthcare. And of course, it's not the only thing, but it definitely was the first report of its kind to really show that we need to care about this. We need to pay attention to it. Since this report, we have had an explosion in literature studying disparities, and it was particularly so since COVID-19. We have seen that disparities have continued to increase and have worsened. We have seen in a variety of racial and ethnic minority patients, including our Black and African American patients, that there are higher rates of stroke, coronary artery disease, hypertension, obesity, diabetes, asthma, higher rates of preventable hospitalizations and amputations, and greater mortality in a variety of conditions, including cancer mortality, diabetes mortality, and famously, regrettably so, maternal and infant mortality. We are likely, many of us are familiar with some of the disparities in dermatology, more famously, the disparities that we see with melanoma in our patients with skin of color. There is less awareness of melanoma in our Black and Latinx communities. And this disparity has now ultimately affected an actual health outcome. We see deeper tumors and later stage of presentation in our Black patients. And there is an increased latency between diagnosis and treatment, even when you control for insurance status. And unfortunately, now what we see is that there is worse survival and mortality data for our Black and Latinx patients. And this isn't just melanoma. We see this with squamous cell carcinoma too, and a disparity in diagnosis of basal cell carcinoma as well. The disparities in dermatology extend throughout diagnosis and treatment. For example, there can be misdiagnosis of normal findings as well as pathological findings, a delay in treatment or insufficient treatment for a variety of dermatologic conditions, many of which we'll hear about today, including the more well-documented ones of atopic dermatitis, psoriasis, hidradenitis suppurativa, alopecia areata, and pigmentary disorders. Additionally, we see disparities in access to care and patient experiences. And though predominantly disparities research here in the United States is done on racial and ethnic minorities, we do have a good amount of data on our sexual and gender minorities. And in dermatology for our LGBTQIA population, we have seen that there are barriers in healthcare access, lower rates of insurance, gaps in coverage. Definitely inadequate care is often given due to a lack of provider knowledge, particularly as it comes to a sensitive approach to our patients. And then that leads to negative experiences with past care, which can lead to a delay in seeking care. There can also be a fear of stigmatization and several psychosocial stressors, which lead to unique mental and physical health outcomes. And it doesn't stop there. We see the disparities extend to education and research as well. Most of us are aware of the decreased content in our dermatology curricula on skin of color dermatology. And again, regrettably and famously, dermatology is widely known as the second least diverse specialty after orthopedic surgery. And there's less research of conditions affecting our racial and ethnic minority patients. So many things contribute to health equity. It's not just unconscious bias, right? We have our history of racism in medicine, how we got here, which is an important thing to know because many of our biases are actually rooted in our history. There is structural bias in racism and all of the isms. These things are built into our policies. Of course, there's health and legislative policy and the big field of social determinants of health. And all of these things are threats to health equity. And today, I'm going to focus on how unconscious bias ultimately affects our care of patients. So unconscious bias is also known as implicit bias, and it is defined as the attitudes or stereotypes that impact our thoughts, our decisions, and actions in an unconscious manner. So you can see that it's not just a scholarly term, it really is a term that has active implications. Now, that being said, unconscious bias is pervasive throughout our society. It is part of being human. If we have a brain, we have unconscious bias. Unconscious bias is rooted in neuroscience and our evolutionary need for survival. It starts in childhood, and that's been well documented in the literature, and it is shaped throughout life by exposure to stereotypes and external messages, often those that we're not even aware of. Bias operates outside our conscious awareness, and it involves fast, involuntary and automatic processing. This is known as system one thinking, which was a term coined by psychologist Daniel Kahneman. It allows us to function in a complex world with billions of frames of incoming information. If we were to consciously think about all of the information that we were taking in at any given second, we would be paralyzed and overwhelmed. So bias is an evolutionary tool that allows us to recognize threat or unlike us or other versus familiar or like us for protection and survival. This is how we notice the face-eating bear. This is how we notice the saber-toothed tiger, right? This is how we protected ourselves from fire. These are things that our brain has evolved to protect us. And it does allow for efficient processing of large volumes of constantly incoming information so that we can make sense of our surroundings quickly, so that we can have an ease in our cognitive load and we can make these decisions very quickly. It also, as physicians, allows us to use cognitive shortcuts, which we use all the time and we use often in dermatology. We use pattern recognition to make quick clinical decisions for efficiency in diagnosis and treatment. And this is how we see a large number of patients in a day. And these quick decisions are often done without even us knowing how we got there, right? Unfortunately, these quick decisions can sometimes be based in inaccurate information. They can be rooted in stereotypes, and it can dictate how we respond to patients and the things that we order in them and how we treat them. Our brain is hardwired to sort and categorize these large amounts of information into boxes and templates. And we use those boxes and templates to then sort incoming information into those templates. So we have an association that we form long in our past, like I said, often in childhood. And as we are exposed to new individuals, new situations, our brain is trying to make sense of everything, and it is sorting this information based on simple characteristics. So by that, I mean race, skin tone, ethnicity, someone's height, someone's weight, someone's hair color, their manner of speech, their name. These are very simple, superficial traits that our brain is quickly using to make sense of what we are seeing. So implicit bias is actually how we use those internalized associations to then determine the interactions we have with the world around us. Now, this is in stark contrast to explicit bias, which is the attitudes and beliefs we have about individuals on a conscious level. And explicit bias is very commonly manifested as prejudice and bigotry. The unfortunate thing is that both unconscious or implicit bias and explicit bias can lead to discriminatory behavior. And this is why we have disparities. Now, a common test that is used to measure implicit bias, as many of you likely know and have taken, is the implicit association test. And this is a computer-based test that relies on differences in response latency when you're pairing associations, such as certain words and skin color, to reveal your hidden bias. And the quicker that you make these associations is an indicator of how strong your bias is. Now, the neat thing about this test is that it really solidified the fact that implicit bias is unconscious. We can't really override it. And there's a lot made about, is the test reliable? Is the test been validated? Can you game the test? And, you probably can. It has been shown that over time, your test results may vary a little bit, but over large populations, this is an incredibly reliable and validated tool that shows us both that the implicit bias is unconscious, involuntary, and also predictive of our behavior. Now, bias is not just black or white, pun not intended. There are several nuances to it. Bias can be favorable or unfavorable, meaning you can have a bias for something and a bias against something. And favorable biases can have equally negative consequences on opposite groups. For example, a bias towards men in leadership can have an equally negative consequence for women. They can be about any characteristic, anything that you can think of, or social group, including your own. And we have documented that many women hold biases against women. Additionally, biases can be mixed or on a spectrum within a group. So it's been shown that the darker the skin color or skin tone, the increased Afrocentricity of facial features, the greater degree of bias is present. And we've seen this with criminal justice sentences. We also can see that stronger accents receive greater degrees of bias, and more culturally unique names receive greater degrees of bias. And this is well documented in the corporate literature, where individuals with more culturally unique names that are not of the dominant group or mainstream names end up actually being called back less for interviews and are less often given the job despite exactly similar qualifications on their CV or resume. And if we wanted to get into the weeds of unconscious bias, there are actually several types of unconscious bias. And I won't go through every single one of these, but many of these we use not only with our patients, but actually come into play with our residency application. For example, affinity bias, preference for those who have similar qualities to you or those you like. We often are not aware of the fact that when we're evaluating people, we are actually potentially evaluating people who are similar to us at a higher level than those who are different from us. And this can be based literally on simple physical characteristics. Anchoring bias, which is preferentially relying on the first piece of information received when making decisions. This is known as a so-called first impression. So for example, if the first thing you look at when you open that IRIS application is somebody's step score, and that step score is lower than what you have in your mind as a threshold of what you think should be in a dermatology applicant, that could ultimately bias all the information you see after seeing that step score, regardless of how good that person's application is. The same thing can be said of someone's physical appearance, and this connects to the beauty bias, which are assumptions equating skills or personality with beauty or favoring those who are more conventionally attractive. And this is often why now more and more programs are blinding photos. Confirmation bias is bias that focuses on information that supports your initial opinion. So you have an opinion of someone and everything else falls into that bucket. And then when it comes to how we talk about applicants, conformity bias can be a big problem, which is groupthink or being influenced by others' views and opinions. So all of these biases can have real consequences for our applicants into dermatology and can play a very big role, in the selection of our workforce. I can't touch on bias without touching on intersectionality. And intersectionality could be its own talk, but Kimberly Crenshaw coined this term and really talked about this in her famous 1989 paper. And intersectionality is the complex and cumulative way in which the effects of multiple forms of bias or discrimination overlap or intersect. And its ultimate fundamental principle is that identity markers do not exist independently of others. It is a convergence of oppression. So you can be a woman and you can be Black, and you may have disparities for each category. But if you are a Black woman, your disparities will be higher than the total of either on its own. So intersectionality has real direct impacts on lived experiences, healthcare outcomes, and the career trajectory. And some of you may have seen these news stories over the last couple of years. Susan Moore, who is a physician herself, died of COVID-19 And she actually recorded a video, and she spoke about not getting the care that she should have gotten for COVID-19, and ultimately she did die. And she alleged in her video of the racial discrimination that she was experiencing. And then we see how this impacts women in the career trajectory. And unfortunately, we see in academic medicine the real statistic that Black women are the highest group that are really feeling forced to leave academia because of their experiences of bias, discrimination, and racism. Now, unconscious bias can sometimes be an uncomfortable topic because we don't like to think of ourselves as physicians as biased. We don't like to think of ourselves as engaging in any kind of behavior that might not treat people equally. Bias often doesn't align with our declared beliefs or endorsed opinions. And the systems in our brain that are responsible for conscious bias and unconscious bias are different. So having unconscious bias is often present even though you don't have conscious bias. So it does not mean that you're a racist person or that you endorse racism. But what's important to know is that bias absolutely leads to discriminatory behavior and perpetuates structural and systemic racism, and it affects our healthcare outcomes. And we have to accept and own that fact. Otherwise, we won't be making a dent in health equity. And honestly, bias is such a double-edged sword. Having it allows us to function efficiently and process information in our environment, like I said, but it's often incomplete information, and it's based on stereotypes, and it interferes with our ability to see people as individuals, the individuals they are. It can interfere with our objectivity, and it's often error-prone. It's wrong. And the harm that it causes often flies under the radar. Much of the harm we don't see. It's either not visible to us in our direct environment, or it's more long-term, and it can be harm that is very, very detrimental to people's lived experiences and their health outcomes, their careers, and it's often unintentional, but it's insidious in this manner. And it often does diverge from our conscious beliefs and our values. And we consider ourselves as physicians as egalitarian in nature, and that can be absolutely true. But unfortunately, if we have a brain, we have bias. So how does it actually cause the disparities? Well, we have stereotypes. These are the images that we are exposed to in our media, in our day-to-day interactions, in the people that we work with. And these lead to biased perceptions, which lead to biased decisions and actions, which ultimately is what leads to disparity. So let's look at some stereotypes. These are common harmful stereotypes that lead to bias, associating Black men with violence. We see this with police violence and brutality all the time, associating obesity with laziness, associating increased height with more competence, and male gender with stronger leadership. These stereotypes lead to discriminatory and disparate outcomes. For example, there are more frequent and harsher criminal justice sentences for racial minority groups. Again, police brutality against Black women, men, and children. Less favorable educational assessments, going as far back as grade school for Black children, and withholding of opportunities, and more harsher and more frequent disciplinary actions. And we see increased hiring and promotion of white men versus any other group. And I will also add increase in higher and better evaluations and promotion and tenure as well. And then, of course, we see our disparities in health. Finally, one thing that we don't talk a lot about, but is a real problem, and many of the individuals participating today can attest to this, is this feelings of othering, feelings of being isolated, feeling invisible, having a decreased self-esteem and decreased well-being, which ultimately affects the opportunities that we pursue and how our career progresses. And we have the data to show, unfortunately, that physicians and nurses exhibit unconscious bias to a similar degree as a general population. And the bias against Black individuals is more common in white and male physicians. So if we care about health equity and having the highest potential of health for all of our patients, it's imperative that we know this knowledge. So how does bias impact impact our patients? Well, this is all documented in the literature, and there's physician-patient interaction effects where unconscious bias can actually affect how close we sit to a patient, how much eye contact we make with them, how much communication we write down in our instructions to them. It affects the time we spend in the room and how much time we spend taking history, how well and thoroughly we examine patients and actually touch them. Also, it affects how participatory our decision-making is. And there has been shown to be a less diagnostic workup and different choices in treatment and less clear follow-up plans. And also we see a difference in healthcare experiences and health outcomes. For the longest time, we just had the data just showed that there was a difference, a disparity in healthcare experiences, but now we have validated data that shows a difference in health outcomes as well. One of the most well-studied and well-documented differences in patient experiences is the vast undertreatment of pain. And this is pain from all sources, in children, in women, in men, patients of color, in particular Black patients. And this is often rooted in the racist and erroneous belief that there is a difference in pain tolerance in Black patients. And that goes back to how it's been rooted in our history, and the forced and inhumane experimentation on Black women, on Black women slaves. Also, we have seen disparities in healthcare outcomes, like I outlined before. And the other piece of data that really brings us home is that their racial concordance among minority patients is a consistent predictor of better patient-physician communication, and more recently has been shown to improve some health outcomes like neonatal mortality. So Black, Indigenous Americans, Hispanic, and other populations of color have repeatedly been shown to receive worse care than white patients on a variety of quality measures, even when other variables are controlled for. So knowing this, how can we let this stand, right? I think we would all agree that this is neither just nor equitable nor equal. Well, dermatology is a bunch of very, very smart people. Unfortunately, we can't outsmart our bias, so we are no exception to the rule here. Dermatologists are more likely to order HIV and RPR tests for dermatitis in our Black and brown patients versus white patients. So syphilis comes to mind much quicker in our patients of color. Racial minorities have been shown to be more likely to experience adverse dermatologic outcomes, present with advanced skin disease and lower melanoma survival rates. And the race concordance has also been shown in our Black and Hispanic patients. And, we've also seen this, like I said, affect our training and ultimately who is selected into our workforce. And our patients' perceptions matter with all this. Context really matters. There's not enough time in this talk to talk about our history, but historically derived and generationally passed down mistrust of the healthcare system is a big factor. Patients' perceptions of their bias exist because of what their parents have experienced, what their communities have experienced, and this gets passed down from generation to generation. And then they have negative experience, and what does that do? All that does is confirm what they already thought was true. So this really amplifies the mistrust in our communities of color, and unfortunately, mistrust significantly affects the patient-doctor relationship. Many of us would agree that trust is fundamental to any healthy relationship, and that's no different for our patient-doctor relationship. Patients perceive the bias they receive, whether we are aware or not. And this leads to less positive engagement in medical encounters, less favorable assessment of providers, and guess what? A lack of follow-up. So then what do we say? We call the patient non-compliant. And this affirms the provider bias. It increases the effects of bias, and it maintains the healthcare disparity. So, unfortunately, we have the evidence to show that unconscious bias leads to non-adherence and continued mistrust of the healthcare system by our communities of color, delay in seeking care, and underutilization of necessary medical care due to past experiences. And I have to tell you, this underutilization of medical care has led to bias built into artificial intelligence systems as well. So when we talk about AI and racial bias, underutilization of the medical care system plays a significant part. There's interruption in continuity of care, lesser quality care, and hopefully I've made it clear that there are worse outcomes as well. And unfortunately, there's a lot of unfortunately's in this talk. The factors that worsen unconscious bias are all the factors that we deal with on a day-to-day basis in our clinical environments: stress and stressful situations, multitasking, fatigue, time constraints, being confronted with complex decisions, or being in vague or ambiguous scenarios. Our mood states, having increased anxiety, or being upset, or having a difficult day, can definitely influence bias negatively. And circadian arousal, it has been shown that bias increases depending on if you're a morning person, your bias is probably worse at night, and vice versa. And a little pivot here, but of course related, because our healthcare workforce directly affects our patient outcomes. There are well-documented effects of bias on the healthcare workforce, all the way from an individual's lived experiences as a child, throughout their educational trajectory, through their post-training career. So we see it with medical school admissions, we see it in the residency application process, we see it in the post-training career pathway, all the way from hiring to promotion and tenure to pay gap and to well-being. Unconscious bias affects the career path because competitive specialty choices, such as dermatology, are influenced strongly by metrics that have demonstrated bias in the literature. There's demonstrated bias in the distribution of awards and honors, such as the AOA, such as an AOA honor or gold humanism, dean's letter verbiage, the descriptions that are used in letters of recommendation, and this is particularly seen with gender bias in comparing men versus women. And then of course, step scores. And we have to ask with step scores, truly, are our board examinations good predictors of physician skill, competence, and the ability to provide excellent care? Students of marginalized groups may not pursue competitive specialties because of their concern that their application may not be competitive enough because of the metrics that they have. And if they do indeed pursue it, the disparities in these metrics and biased decision-making in the application review process and the interview process adds to further disparate outcomes. So you can see how there's layers upon layers upon layers of bias built into our underrepresented in medicine students. And this is part of the rationale for holistic review, as well as adjusting your interview process to incorporate some standardized behavioral interview questions. Why do we care about this? Well, the underrepresentation of our of certain populations, racial and ethnic populations in dermatology, is well documented. And underrepresented in medicine means underrepresented compared to the numbers in the general population. So it is not specific to certain racial and ethnic groups. It will change as the demographics of our country change, but presently that includes Black or African American individuals, Hispanic and Latinx, and Native American or Indigenous individuals. So the data doesn't necessarily well account for mixed race and ethnicity groups and gender sexual minorities. Unfortunately, the data has not been collected very well either. And when we talk about the underrepresented medicine student, we have to acknowledge that there is a greater distance traveled. A colleague asked me once, how do you measure distance traveled? And we don't have a way to measure this, right? How do you measure that? It's a very complex, nuanced metric. But the fact of the matter is that our racial and ethnic minority students often do have a greater distance traveled. Often they are first generation students, the first doctors in their family. And so they're navigating this very complex higher educational system without guidance from parents with firsthand knowledge. That goes a really long way. And even if their parents aren't doctors, other professionals who've gone through higher education beyond undergraduate college makes a big difference. They may be balancing education with life demands, such as working to help their family, and this can interfere with their educational commitments. And there may be other financial barriers due to the high costs associated with the educational trajectory, which is famously expensive in medicine. They also have very different medical school experiences. And if you haven't heard of this or talked with your underrepresented medicine students, it's really heartbreaking when you hear about their lived experiences of both unconscious and conscious bias. They often are receiving improper guidance or active discouragement from their advisors and counselors. You may not be seeing or hearing that. There are fewer networking and mentorship and sponsorship opportunities for them. And of course, the micro and macro aggressions that they're receiving, not only from faculty, but from maybe residents, maybe peers as well, lead to feelings of demoralization, even dehumanization, and a sense of isolation and increased exclusion. And this ultimately leads to feelings of low confidence, self-doubt, and questioning their belonging. And it doesn't stop, of course, with racial and ethnic minorities. It does affect women too. Gender equity could be its whole other talk, probably an entire day. But in women, we have well-documented evidence across the board of lower pay, lower career trajectory, progression through promotion and tenure, so-called leaky pipeline, right? We see this for a variety of minority groups. We now have gender parity in medical school admissions, but we do not have that parity as we advance along the promotion and tenure pathway. So why do we care about diversity, inclusion, equity in our workforce? Well, number one, I think I've established that it's good for our patients. Racial concordance in healthcare visits for minority patients improves patient trust and satisfaction. The patients feel like, and they are getting better care, and they follow up more, and their overall outcomes are improved. On top of that, minority physicians have been shown to be more likely to care for patients of their own racial and ethnic groups, care for patients with more complex healthcare needs or poor health status, practice in areas of high need or those that are underserved, and care for patients who are low or no income. And representation matters. We've heard of the common phrase, you can't be what you can't see, and this is very true. Diversity promotes further diversity. If you see diversity, you are more likely to think of yourself as belonging and that there's a place for you. There is such a power, such power in shared experiences. So if you are able to talk to a mentor, whether it's a peer or someone who is actually, a faculty member who can understand what you've been through, who can give you that guidance, who is going to advocate for you, it's going to go a long way. So I hope I've established clearly here that when doctors don't represent the demographics of the general population, we all suffer, our patients suffer. So we really do have to talk about how do we mitigate implicit bias. So counteracting and decreasing bias is going to be how I'm going to take us home. Does unconscious bias training work? Because there's a lot made about unconscious bias training. And, some people say it doesn't work. And some people say, well, you have to do it for everyone. Well, my answer is it just depends. It depends on what you're doing. Giving it an implicit association test and calling it a day is not going to do it, right? Unconscious bias work really is longitudinal. First, there's awareness that's involved, and then it's the work that comes after that. So it really depends on how you're approaching it. And I want to go over some strategies on how we can mitigate bias. Can we defeat it? I don't know, right? We live in a society that still, has, dominant groups and minority groups. And, in a couple of years, we're going to be a minority majority. But until then, the messages that we receive are going to continue to come in. And so do we defeat bias? That would obviously be the goal, but if we can at least decrease it, moving forward, I think we are getting somewhere. So first of all, awareness. You can't overcome that which you're not aware exists. And this is one of the big best uses of the implicit association test. It might give you some idea, do I have a bias? And you might be very surprised by the results. And it has been shown over and over again in the social psychology literature that awareness does indeed change behavior. And you can pay attention to your thoughts. I would encourage you, if you're in a situation that, you're interacting with someone who is different from you in some way, pay attention to the thoughts that are going through your head. This is called metacognition, and we do it all the time, really. But, listen to what's running through your head and see if you can detect a bias in yourself. And of course, awareness extends to just knowledge in general, knowledge about all topics relating to diversity, equity, and inclusion. Individuating refers to the conscious effort on focusing on specific information about someone. And it's a fancy word really to say, we need to get to know people. And individuating or individuation reduces the influence of our predetermined stereotypes. You can't use a box that's generic on someone that you really know well. right? So specific information about individuals prevents us from filling in erroneously with partial information that could be wrong. So get to know people so the stereotype goes away. And again, this is how diversity promotes further diversity. Perspective taking is the conscious attempt to envision ourselves in another person's situation. And it doesn't seem on the outset like it would go far away, but truth be told, perspective taking is the cognitive component of empathy. It's thinking what it would be like, putting yourself in that patient's situation. And this actually famously has been shown to improve pain medication treatment for patients when nurses are actually told to think about what the pain would be like. They actually have shown that it has decreased the disparity in pain treatment. So if you can look at other people and see yourself, you'll start to change how you treat other people because you decrease that othering phenomenon. Cultivating common ground is how we connect over our mutual interests and shared experiences. Finding commonalities decreases that othering, decreases that sense of us versus them. And this includes having increased conversation. And many of these strategies kind of bleed into each other and are connected. It's hard to do one without the other. But essentially what we're trying to do is have more interaction with people that are different from us. And that's what intergroup contact refers to. It's actually just expanding your in-group. Do people all look like you in your in-group? Well, expand your in-group to people who don't look like you. And it's been shown that if we behave in ways that counter our bias, we can actually weaken the bias. Having intergroup contact and meeting people that are counter to our stereotypes actually helps our brain form new associations and helps to decrease the power and influence from existing associations. That's pretty cool. That's us taking advantage of our brain. Counter stereotyping is when we see people counter to our stereotype of them. Our stereotypes don't hold up. So this is another way that diversity and inclusion in our workforce can help us to fight bias. And though a full talk on allyship and upstanding intervention and responding to microaggressions isn't something that I have time for today, I would be remiss if I didn't mention how important it is when we are trying to mitigate bias to respond to microaggressions and to have microaffirmations and the appropriate mentoring and sponsorship. And I'll briefly touch on this before we end today. Microaggressions are the everyday verbal, nonverbal, and environmental slights, snubs, and insults that communicate negative or hostile messages to individuals in minority and marginalized groups. And usually these are unintentional. Well, why are they called microaggressions? Well, they cause pain and they cause a significant amount of psychological distress, and they can sabotage an individual's potential and their opportunities. You see here the mosquito bite, death by 1,000 mosquito bites is one of the things that microaggressions refers to, and the micro term does not actually refer to the pain of microaggression. The pain can be very significant, but it's the fact that the events are seemingly small, but they are frequent and they are chronic. We did this thing this year in our program where we actually did a microaggressions role play, and I'd encourage all of you who are in academic programs to think about doing something similar. And you can take when you get these slides, you can print this out and make a cheat sheet for yourself. But these are all different statements that can be used when you are witnessing a microaggression, or if you are the receiver of a microaggression, to help you know what to say, because often in that moment you feel paralyzed, like you don't know what to say, you don't know how to respond, and often you freeze up, and we think about what we should have said later. And so having the tools and the phrases to say in the moment can be very helpful. And I would also encourage you to practice these things, because the more we practice, I always call it muscle memory. We build that muscle memory. We get used to responding and using these phrases, and they come from sort of the back of our brain more to the forefront of our brain. And if it helps, print this out and put it on a note card and carry a cheat sheet around you. It's not necessarily like you're going to pull it out in the moment, but you can frequently look at it and can give yourself an idea of what is it that I need to say if I hear something. So we really do have to be intentional when we're trying to respond to microaggressions, because if we don't practice it, we're not going to be able to say it in the moment, because that moment is fraught with an emotional, usually there's some kind of, it's emotionally charged. It's often done quickly. It's done in front of patients in busy days. So these are all things that can cause the moment to pass. In addition to responding to microaggressions in the moment, we can also counterbalance some of the harm of microaggressions. Microaffirmations are these small but very intentional acts and gestures of caring, graciousness, and inclusion. And they can include such simple things as just active listening and empathetic verbal and nonverbal communication. So this can just be, putting a hand on someone else's hand. This can be, active listening where you're, having eye contact and you're nodding and you're, showing that you're actually caring about what someone says. It can be an acknowledgement of painful experiences, even when you can't identify with them. Many of us may not be able to identify with the experiences that some of our students go through, but we can acknowledge and, perspective take when we hear these things. And even that alone can really help to validate someone's experience. We can be very active and intentional in our meetings and our projects and soliciting input and opinions and being really mindful of what is being said in the room. And, again, pulling up those phrases when it's called for. And then being really mindful of recognizing and giving people credit for their input and their ideas. This famously is not done as much for women as it is for men. And, you may not realize if you are of the dominant group, all of the microaggressions that are felt by women and people of color. And here's that intersectionality, women of color every single day. And so it's like carrying around these loads, and every time you have another microaggression, it's another rock. It's onto that load. It's another mosquito bite. It's another paper cut. And these things in and of themselves don't seem like big deals, but when you accumulate them, they really cause burden. And unfortunately, there's a lot of real outcomes of this. This is why we see the trajectory that we do, where we see a lot of women of color leaving academic medicine, and even leaving medicine entirely. And just to bring it on home to my initial opening story, the power of saying someone's name cannot be understated. And with a name like, my maiden name is Manlapudi. So with a name like Sacharitha Manlapudi, the amount of bullying I got over my name, I think I will always bear some scars from it. But, it doesn't have to just be active bullying or making fun of someone's name. It could be just, avoiding saying it. And, when you talk to someone, if you don't know how to say their name, you might just avoid saying it altogether. It's so much power that goes into just asking someone, how do you pronounce your name? And to not be afraid of that. And then saying it until you pronounce it correctly, and then using that name in conversation with them. It really brings a sense of validation and inclusion to any interaction. And mentorship and sponsorship goes such a long way. And I want to speak to everyone here in that oftentimes what happens with our minority faculty is they're the ones who are mentoring and sponsoring our minority students. And that is important because of that, the power of those shared experiences. That is very important. However, in programs where there may not be as many minority faculty, we don't want those students just to not get mentoring. So it's important for all of us, regardless of our race or ethnicity or gender, to be intentional and proactive in providing that guidance, that professional development, those career opportunities, and advocating for our minoritized learners and colleagues, regardless of whatever our own identity group is. So, just briefly to take a further step back, what can organizations do, no matter if you're, large healthcare organization or just a program, is taking a stance and saying, I care about this. I'm going to commit to change. And you may not know what you're going to do, but taking a stance is the first step. Get some metrics, whatever it is that you want to measure. If you want to measure, if your residency practices of your holistic review is actually improving diversity and inclusion in your program, get the data, see how many people you interview now, and see if you incorporate holistic review or different interview techniques if your match rate of underrepresented medicine students increases. create systems of accountability to capture those transgressions in behavior, to capture microaggressions so that people have somewhere to go to so that this can be measured. Financially prioritize equity, diversity, and inclusion. It's famously underfunded, and it should get the priority that all other endeavors do. Examine your recruitment practices and who's at your leadership table. Integrate equity both into your educational and clinical environment. See how you might be excluding some populations in your clinics. Are you accessible to persons with disabilities? Are your magazines in your lobby reflective of all of your patients? Re-examine your curricula with an equity lens. And, we have a lot of things coming through the pipeline here from many different areas on equity curricula, which will really, I think, help programs who, maybe they don't have to reinvent the wheel. They don't have to, develop a whole curricula series from scratch. There's going to be a lot of available resources, and we are working on that. Approach EDI with those same standards of excellence that you expect with all of your other institutional aims, and support people in the work that they want to do. And please be mindful of the minority tax. The minority tax is a disproportionate burden on underrepresented in medicine and people of Black, Indigenous, and people of color faculty to participate in EDI service and work. And it's not to say that many individuals in these groups want to actually be a part of EDI work, but often they're expected to be the ones to lead it, and everyone else just sort of steps back. And unfortunately, this really can place undue time burdens on those faculty. It's not always compensated or valued, of course, the same as other work. They don't necessarily get to engage in some of the clinical topics or the research they want to do. And it really is hard work. It can lead to increased burnout. So please be mindful of that. And it can take time away from other professional, even personal interests, and create more opportunities for trauma. These topics can be hard to talk about. They can be uncomfortable. They're not received the same way. They're not evaluated the same way. I can't tell you how many faculty and colleagues I've talked to that say when they give talks on these topics that there's just crickets, right? And that affects how people's feelings of their competence. And so just please be mindful of this tax. So what else can you do as individuals? Well, hopefully this was helpful to you, and immerse yourself into taking responsibility to learn about these topics and ask those important questions. You may not have the answers, and that's okay. But ask, who's coming to our clinics? Who's not coming to our clinics? Who's in our residency program? Who isn't? Do we have any faculty of color? If not, why not, right? Ask those questions. Please learn about the history of racism in medicine. It is so crucial. The book to read is Medical Apartheid by Harriet Washington. It is an incredibly important book so that we can get the historical lens on why some things are the way they are. Learn and care about how you use your words. And all of us, this is very near and dear to me, to all of us, having power and privilege. We all have, as physicians, some amount of privilege and power, and use the privilege you have. And if you have greater privilege, take advantage of using that privilege and be an ally. Ask your learners what their experiences are, and listen when they talk to you. And oftentimes you may be the only one, or you may be the first one, and it's really scary, but know that there's not always a roadmap, but there's also a lot of resources available, and there's a lot of people who are willing to work with you. And I actually really, for one, believe that we need to have more collaboration around EDI work, less reinventing of the wheel. And I think that'll help our burnout too. So just know that you're going to fail. When you do EDI work, you're going to fail. And that's okay, because that's where our growth is, right? So be ready to fail, but learn from that. Try again. Don't get discouraged. And with that, I want to thank you so much for your time and your attention, and again, the opportunity to be able to speak with you here.
Thank you so much, Dr. Bowers. We learned a lot that we'll be thinking about throughout the day and for weeks to come. We have a couple of questions in our chat, so if you don't mind, I'll just read those out.
Sure.
How do you think, this is from Dr. Papik, how do you think microaggressions or harassment from patients specifically affects medical students and providers? Any tips for how to manage offensive patients without derailing the appointment? Yeah,
that's a really great question. And I will tell you, this is a work in progress for all of us. And I don't think that I have, all the answers, as I'm still trying to figure that out myself. Number one, I think it's important to acknowledge the fact that this happens, and we don't always hear about it as faculty. And so if we don't actually address this topic and learning about how microaggressions manifest, we're going to be wholly unaware and we're going to miss it. And setting up a culture that's saying, I want to hear about these things. If these things happen, I want to know about it. And this is something that we can tell our medical students at the beginning of their rotation, that we can have, in our course materials. It's important to have a policy. Now, policy is not all the answers, right? You can have an awesome policy and not act on the policy. So having that system of accountability, how are you going to capture that? And an orientation for your residents, talking about what is your policy around microaggressions and harassment and bias. How do you collect that information? And even so much as saying the words like, this isn't okay. If this happens, let's work through it. I want to know about it. And you're not always going to have the answers. And I think the patient scenarios are always going to vary. If you have patient scenarios that are either unstable scenarios, patient is either unstable, or is under the influence, or is just not, there may be situations that are emergent. You may not be able to intervene the way you would if a patient was, of a sound mind and stable. So recognize that there will be a difference in how you handle different scenarios based on the clinical presentation. I think that it can often be maybe a little bit easier than we even think it is. It can be one line, and that's what those phrases to speak up can be helpful with. But one thing that we're even talking about in our program is having a set phrase that everyone knows that they can say. An agreed upon statement that isn't tolerated here. And it'll depend on what the scenarios is. If you're talking about a woman versus, a patient, a student or resident of color, but having some type of simple agreed upon phrase that you say that kind of stops that interaction, interrupts it in the moment, can be really helpful. The other thing I would add to that is, this is very, very important, is debriefing afterwards with your student and resident is so huge, because you might miss it in the moment, and that happens, right? We freeze. Or you might say the wrong thing, it happens. We're human. We're trying to figure this all out. And I, by no means, I'm still trying to figure this all out with my own program, with myself. But debrief afterwards, because number one, what does that do? That acknowledges to your student or your resident that you noticed, okay? And that number two, you're not okay with it. Number three, how are they doing? How did this impact them? Number four, what can you do now? I mean, it's okay to acknowledge that, boy, I messed up. I should have said something in the moment. What can we do now? And then use it as an opportunity to spur some discussion. There may have been a resident in the room, a student in the room. There may be like a family medicine resident in the room. And of course, there's a faculty member. So there's a lot of people who witnessed this. And I think those discussions should not happen in isolation. They should involve the whole team, as well as a separate private discussion with the person who was the most impacted about their trauma. And then lastly, check with your GME program or your medical school to see what kinds of policies they have. A lot of institutions now have systems of accountability that you can adopt that can more formally capture these incidents and give you a framework for how to formally respond. The tough thing is we take care of patients, right? And this is always a conundrum, is when do we say, this patient can't come here versus, taking care of patients. And I think that this has been, talked about somewhat on the national stage. But, and I don't have an easy answer for that, but we do the best we can in trying to take care of our patients and doing due diligence to being physicians, but also not forgetting that we have to care about our learners.
Thank you so much. I think that is unfortunately the time that we have, but we appreciate your talk so much. I'm getting an incredible response on the chat, so please feel free to read all of the comments from everybody.
Thank you so much.
Dr. Allen, would you like us to adjourn for lunch?
Yes, I just want to say thank you, Dr. Bowers. It just solidified the things that we were actually discussing even within our own program, but helps us to be aware of those things that we still have blinders. We'll have those blind spots, and making sure that we hold ourselves accountable.